of Holland and Hart. Happy to spend the next hour with you talking about surprise billing. So today, here's what we're going to do. We're going to talk about surprise billing. What is it? How prevalent is it? Next, we're going to do a brief, and I mean brief, one-slide summary of the federal legislation regarding surprise billing. Next, we're going to do a summary of the surprise billing and the provider directory provisions. These are new provisions that were put into the NAIC Model Network Adequacy Act at the end of, in November of 2015. We're going to go over those. And then the last thing we're going to do is a discussion of surprise billing laws enacted and legislation pending in various states. So surprise billing, what is it? Well, in the simplest sense, it's a term referred to describe charges arising when an insured individual inadvertently receives care from an out-of-network provider. The situation can arise in an emergency when the patient has no ability to select the emergency room, the treating physician, or ambulance provider. It also may arise when a patient receives planned care from an in-network provider. From an in-network provider, often in a hospital or ambulatory facility, but other treating providers are brought in to participate in the patient's care and are not in the same network. This could be most commonly facility-based providers, including anesthesiologists, radiologists, pathologists, surgical assistants, and others. In some cases, entire departments within an in-network facility can be operated by subcontractors who don't participate in the same network. And in non-emergency situations, the in-network provider or facility generally arranges for the out-of-network treating providers. So if you're an insured patient and you get a surprise medical bill, there can be two sort of impacts of that. One, that the bill reflects the difference in patient cost sharing between an in-network and out-of-network providers. For example, a managed care plan that provides coverage in and out of network, sometimes called a PPO plan. A patient might owe like 20% of an allowed charge for in-network services and 40% for out-of-network services. A second component of surprise billing is due to balance billing. Typically, healthcare plans negotiate fee scheduled or allowed charges with network providers that reflect a discount from the provider's full charges. So network contracts typically prohibit providers from balance billing patients or billing the patients the difference between the allowed charge and the full charge. Because out-of-network providers have no such contractual obligation, patients can be liable for the balance bill in addition to any cost sharing that might otherwise apply. So how prevalent is surprise billing? Well, I'm relying upon a study that was done by the Kaiser Family Foundation dated March 17, 2016. In that study, it was found that among insured non-elderly adults struggling with medical bill problems, charges from out-of-network providers were a contributing factor in about a third of the time. Further, nearly 7 in 10 of individuals with unaffordable out-of-network medical bills didn't know the healthcare provider was in their plans, was not in their plan's network at the time they received the care. According to this study, the data on the prevalence of surprise medical billing and cost to consumers is limited at this point, but they did also include other research studies that the Kaiser Family Foundation study mentioned. One was a national survey that found that 8% of privately insured individuals used out-of-network care in 2011. 40% of those claims involved surprise out-of-network claims. The survey found that most surprise medical bills were related to emergency care. It's an interesting study in 2011 by the New York Department of Financial Services that was mentioned in the Kaiser study. And New York studied more than 2,000 complaints involving surprise medical bills and found the average out-of-network emergency bill was $7,006. Insurers paid an average of $3,228, leaving consumers on the average to pay $3,778 for an emergency in which they had no choice about the provider that provided services to them. The same New York study found that 90% of surprise medical bills were not for emergency services, but for other in-hospital care. And they're the same sort of specialties I mentioned earlier, anesthesiology, lab services, surgery, and radiology. Also, a private study of data reported by health insurers in 2013 to the Texas Department of Insurance. This is also a study mentioned in the Kaiser study. Suggests that emergency room physicians often do not participate in the same health plan networks as hospitals in which they work. 3 Texas insurers with the largest market share reported that between 41% and 68% of dollars billed by emergency physicians' care at in-network hospitals were submitted by out-of-network emergency physicians. So they analyzed the provider directories of these 3 insurers, and they found that between 21%, 45% of the in-network hospitals had no in-network emergency room physicians. Well, here's the one slide on federal law regarding surprise billing legislation, and basically, I got this from the National Academy for State Health Policy, and they indicated that the most important legislation, federal legislation that's been passed with respect to surprise billing was the last one of the 3 listed on this slide, the Omnibus Budget Reconciliation Act of 1989, which governs physician fee schedules for Medicare. The Act limits non-participating Medicare to only billing up to 115% of Medicare's fee schedules. And also balance billing is prohibited in Medicare Advantage with the exception of private fee-for-service plans. According to the Kaiser Family Foundation estimates, a $2.5 billion reduction in balance billing was achieved as a result of the provisions of this act between 1983 and 2011. So now we're on to talking about the NAIC Model Network Adequacy Act changes pertaining to surprise billing and provider directories. And for those of you who don't know, these provisions were approved by the NAIC in November of 2015. It was basically a big overhaul of the Network Adequacy Model Act. I don't think any states have actually adopted the revised, in full, wholesale, the NAIC Model Network Adequacy Act. And there was a sort of, that act was revised in part because CMS was making suggestions that perhaps they should devise a one-size-fits-all network adequacy rule that would apply across all government programs, and the state sort of pushed back on that and said, gee, we think that a one-size-fits-all rule is not going to apply, therefore give us an opportunity to update our Model Act, and we'll set about trying to encourage the states to pass it. And so CMS held off on their one-size-fits-all rule and encouraged the states to pass this the NAIC Model Act. So you can see from this slide the sections about out-of-network surprise billing, Section 7, Section 8, and the provider directory. Those are all new sections in this overhaul of the rule of the Model Act. So essentially, the surprise billing requirements require the carrier to establish a program for payment of out-of-network facility-based providers where the difference in the billed charge and the plan's allowable amount exceeds $500. And it requires that the carrier may pay submitted facility-based out-of-network provider bill, or if they don't want to pay the bill charges, they can pay in accordance with benchmarks set by the state, with the benchmark deemed reasonable if it's higher of the contracted rate and a percentage of Medicare for the same service in the same geographic area. And then it also provides for a provider mediation process for out-of-network providers who object to the benchmark rates. Now, there are notice requirements under the NAIC Model Act with respect to providing patients or enrollees notice that there will be a out-of-network provider potentially by the participating facility, by the carrier. And then in a minute I'm going to talk about the other notice requirement, and that is by the out-of-network provider if they want to balance bill. But the notice that an out-of-network provider services may be provided at an in-network facility must be provided to covered persons by a participating facility for non-ER services at the time of scheduling or prior authorization, which must be signed by the covered person at the time of admission, and for ER services with the billing notice. And there actually has to be a notice within 10 days of an appointment for inpatient or outpatient services pursuant to the facility's contract with the carrier. And then the carrier has to give notice at pre-certification, including informing the covered person of the possibility of higher cost sharing and options available to access participating providers. And here's a notice requirement for non-participating facility-based providers. They can't balance bill unless they notify covered persons of their payment options in a payment responsibility notice when they send their bill. And, I'm sorry, unless they send this notice. And the notice requires that the services that they say, that they provide information to the covered person that the services outlined below were performed by a facility-based provider who is a non-participating provider with your health care plan, and telling the enrolled person that they're responsible for paying their co-payment, co-insurance, or deductible amount, and that for the remaining balance, they have three choices. They can choose to pay the balance of the bill, or if the difference in the bill charge and the plan's allowable amount is more than $500, they can send the bill to their health care plan for processing pursuant to the carrier's non-participating facility-based provider billing process, or they can engage in the provider mediation process, or they must be informed that they can rely on other rights and remedies that may be available in the state. So only if the non-participating facility-based provider provides this notice to the covered person in advance will they be allowed to balance bill. Moving on to the new provider directory requirements that were contained within the revamp of the NAIC Model Network Adequacy Act under this new Section 9. This is basically requires the carrier to post a searchable electronic and accurate provider directory of each of its network plan, and it has to be updated at least monthly, has to be audited at least reasonable sample size and such audit available to the commissioner upon request, has to contain criteria used to build networks and provide a consumer hotline to notify the carrier of errors in the directory. This Section 9B of the Model Act update I thought was interesting because it requires the searchable electronic provider directory to include, for healthcare professionals, name, gender, participating office location, and the like. It also requires facility affiliations if applicable and participating facility affiliations if applicable. So you can see that's more information than would have been required in the past to be able to give the covered member more information about how they can stay in network, essentially. So there are about 27 states now who have either passed surprise billing legislation or are considering it. For the 2015-2016 legislative session, 19 states proposed legislation addressing surprise billing. Of those, 7 states successfully passed legislation, and you can click on to this National Academies for State Health Policy, and it will tell you, it will describe to you, give you information about the bills in these 7 states that were passed. I'll give you a really good idea, essentially, sort of the kinds of laws. But I mean, generally, the laws that were passed in California, Connecticut, Florida, and Utah, they capped or limited charges for services delivered out of network. Connecticut law, Florida, Georgia, Minnesota, and Texas improved patient disclosures, cost estimates, and network transparency. Georgia law assessed the impact created legislation assessing the impact of potential parameters for balance billing. And Florida and Texas established a process to resolve disputes. So far this year, and this list doesn't include Nevada, but we're going to get to Nevada. In 2017, 7 states so far proposed surprise billing legislation. Rhode Island their bill would allow the state's health insurance commissioner to establish a process for patients to challenge disputed medical bills. Georgia would mandate caregivers to improve transparency with patients regarding which physicians will be participating in their care. Both bills do not require the hospital to explicitly state which physicians would be considered in network for each patient, nor would it eliminate patients' out-of-pocket expenses such as deductibles or copays. In Ohio, the proposed legislation would prohibit emergency physicians from billing out-of-network payers at a higher rate than payers' in-network reimbursement rate for emergency care. It also aims to create a patient scheduling services to provide patients with more information about potential out-of-pocket costs. In Oregon, the bill would regulate the rate insurance companies pay out-of-network providers for services to ensure fair and reasonable payment. In Arizona, the bill would allow Arizona Department of Insurance to intervene in some balance billing cases. The bill would apply to instances when patients were unable to determine whether the medical provider was in network and feel they were unfairly charged. And patients would also be responsible for paying normal copay amount and deductible in most situations. With the legislation pending in Utah, it aims to regulate the rate out-of-network emergency physicians can charge payers for emergency. And the law would institute a national benchmark for usual emergency care to determine the maximum price. And finally, in Texas, the proposed legislation, the state would be allowed to mediate balance bills for care administered by out-of-network physician and in-network freestanding emergency departments and in-network hospitals and for all providers. It also calls for an expansion of the state's disclosure requirement and would require providers to include a disclosure stating this is a balance bill that may be eligible for mediation. So generally, I think the one resource I found very helpful was the July 25th Robert Wood Johnson Foundation report. And this report is a really good report for sort of understanding the whole landscape of states attempting to deal with this out-of-network balance billing issue. And what they did was they studied the issue in 7 states: California, Colorado, Florida, Maryland, New Mexico, New York, and Texas. New Mexico doesn't have any balance billing laws, unlike the other states, but they thought it was an interesting state to include in the study because it sort of has a different market structure than some other states. So what they found after kind of doing the study is that states have generally taken the following 4 approaches to protect consumers from balance billing. One is enhanced disclosure and transparency requirements. 2, prohibition on balance billing by providers. 3, requirements for insurers to hold customers harmless from surprise charges. And regulations that ensure fair payment for billed services. So generally they looked at sort of issues that kind of cut across a number of different states, and they went and talked to the stakeholders, and they asked them, you know, sort of what's really going on here in your particular state about, you know, kind of the market dynamics and the like, and the various players in the market, the insurance companies, the providers, and the covered persons. And here's kind of, I'm going to give sort of a summary of what they said in the report about the various issues. One was the issue of protecting consumers. They said that stakeholders report that the state balanced billing legislation has been reasonably effective in keeping consumers out of the middle of disputes between non-network providers and healthcare plans over the correct level of payment. When we get to a discussion of Nevada at the very end of the presentation, that's one of the things that, listening to the, you know, sort of the proponents of that legislation, that is kind of the primary motive for the legislation, and that is to find a way to keep the covered members out of the process. Another one of the issues that sort of kept coming up was emergency versus surprise billing settings. In other words, there appears to be a greater consensus about protecting consumers from balanced bills in an emergency situation other than for other surprise billing situations. Not unexpected, since consumers have the least control in medical emergencies in terms of determining or selecting who their provider will be. Another issue that came up is balancing the interest of insurers and providers. So the study said basically that the difference between a direct ban on balance billing by providers and requirements that some states have on insurers to hold their plan members harmless mainly revolves around which stakeholders are at financial risk. The study says under hold harmless rules, the insurer is at risk for paying whatever the provider charges. And under the balanced billing band, the provider is at risk for accepting an amount less than the amount billed, or even an amount the provider considers reasonable. To the extent that either stakeholder is dissatisfied with the process, there's a greater chance consumers can get caught in the middle despite the protections built into the law. So the study says that to balance the interests of all stakeholders, several states have either incorporated stronger approaches to setting rates or included a dispute resolution process. A state requirement that plans pay based on their own usual and customary rates without more specific rule leaves the insurers with greater leverage. Another issue that the study said sort of surfaced in basically talking to stakeholders and the like was the role of mediation and dispute resolution. And mediation or dispute resolution processes have a mixed record to date in California and Florida, says the study. Regulators in Florida indicated that the potential cost to participate for providers is a barrier, particularly if they are unsuccessful. In California, regulators reported that insurers have little incentive to participate because balanced billing is already prohibited for emergency services. In a few minutes, we're going to talk about both California and Florida. But the study goes on to conclude that low use of dispute resolution processes may signal success if it creates an incentive for health plans and providers to negotiate or accept rates that are viewed as reasonable. Another issue the study found kind of surfaced in the whole dialogue about resolving this issue. And the study says that most of the states that they studied have made some provision to improve consumer disclosures. Disclosure provisions may be used in lieu of more direct protections or to complement other measures. But it remains an open question how much value consumers derive from disclosure rules. One consumer advocate suggests that disclosure rules can yield good information, especially if it means more accurate and easy to use provider directories. However, she thinks that disclosures do little protect consumers from balanced billing. At best, it helps a small subset of consumers who take an active role in reviewing their disclosures. At worst, and more likely, as some respondents note, it is more a piece of paper that consumers receive when they have a health care encounter without improving their understanding of the financial implications of receiving in versus out-of-network care. One health plan highlights its efforts to use care managers to alert members which specialists are in network when they schedule care, information that is useful because it arrives at a time when the member is actually seeking that information. The study says that in terms of the impact on the market environment is critical because it creates a context for how states approach consumer protection relative to balanced billing. And the design of provider networks vary in part because supply, distribution, and expertise of providers vary from state to state, as do the concentration and market leverage of health insurers. And the presence of non-network physicians and other providers in network hospitals has been documented in Texas, but occurs in other states as well. In some markets, insurers may have the leverage to encourage or require participating hospitals to guarantee that all of their clinicians contract with the network. But in many markets, physicians and other providers have enough market power to block these efforts. So, then it talks about the politics of balanced billing legislation, and you can really see that in the Nevada process. Passing meaningful consumer protection legislation can be challenging, particularly since legislators must balance the interest of insurers, providers, and consumers. Although all stakeholders may agree consumers should not be caught in the middle of the payment disputes between insurers and providers, they tend to disagree on how to implement that protection. Both the degree of market concentration and the political cloud of providers and health plans can influence the ability of states to pass legislation to protect consumers. So Robert Wood Johnson concludes only a few states have acted through regulation or legislation to protect consumers. And most of the legislation is typically limited to protections in which consumers have limited control in hospital emergency departments and when treated by non-network providers while at an in-network facility. And so basically they say that the approaches, the states studied for this report took varied approaches but shared the goal of ensuring consumers are not liable for charges that are mostly outside their control. So it's interesting to hear about sort of that study, and because we don't have time to go through every state and every law that's been passed, just to kind of hear the broad brush difficulties and challenges there are to pass such legislation. So what we're going to do next is we're going to go through essentially the three laws for the 3 states that have sort of led the way in creating balanced billing legislation that sort of led the way for all of this recent activity that's occurred in the last couple of years. And New York has been is widely regarded as having the first comprehensive state law protection against surprise medical bills. So New York's law limits surprise medical bills from out-of-network providers in emergency situations and in non-emergency situations when patients receive treatment at an out-of-network, at an in-network hospital or facility. For emergency services, patients insured by state-regulated health plans are held harmless for costs beyond the in-network cost-sharing amounts that would otherwise apply. For non-emergency care, patients who receive surprise out-of-network bills can submit an assignment form authorizing the provider to bill the insured directly, and then are held harmless to pay no more than their otherwise applicable in-network cost-sharing. In both situations, out-of-network providers are prohibited from balance billing the patient. So if you're a provider and you dispute the reasonableness of the health plan reimbursement, you can appeal to a state-run binding arbitration process to determine the payment amount. So New York requires a plan to establish a reasonable payment amount, and the plans have to disclose their methodology and how it compares to usual and customary rates, which are defined as 80%, the 80 percentile of the amounts made available by Fair Health. An independent entity created in 2009 to maintain a database of charges for medical procedures. So if the provider is not satisfied with the amount paid, the state has created an independent dispute resolution, has created an independent dispute resolution process. The IDR process uses licensed physicians in active practice. They can choose either the provider's original billed charge or the plan's original payment, as opposed to any amount in the middle. Making the decision, this independent dispute resolution process must consider the patient's characteristics, the doctor's training and experience, and the usual and customary rate based upon the Fair Health data. As an alternative, the parties can negotiate a settlement on their own and notify the IDR. The IDR can also direct the parties to negotiate a settlement. The IDR system is designed to create incentives for providers and plans to set their charges and payments at more reasonable levels. New York also has a more extensive set of disclosure requirements for health plans, hospitals, physicians, and other providers. The goal is to make it easier for consumers to look at out-of-network benefits when doing comparison shopping prior to selecting a plan, and to understand the potential charges prior to using services from an out-of-network provider. The plans are required to maintain accurate and regularly updated provider directories, provide clear statements of how bills are calculated, and provide examples of out-of-pocket costs for frequently billed services. Hospitals are required to provide lists of their standard charges, the insurance plans with which they participate, and whether their employed or contracted physician groups participate in these insurance plans. And physicians are required to make available their participation status with health plans and their reasonably anticipated charges on request. If a doctor is scheduling a hospital service and the particular doctor knows who else is going to be providing additional service or be in the room, he or she must disclose whether those doctors participate with the patient's insurance. So as one stakeholder described the new rules, each party will be responsible for disclosing the information about which it has knowledge, probably the most complete disclosure requirements of any state. Florida is another state that sort of led the way. It prohibits balance billing for emergency services, but only for HMO products. Plans are required to pay the lesser of the provider's charges, the usual customary charges for similar services in the community, or a charge mutually agreed to by the plan and the provider. It also prohibits out-of-network providers from balance billing HMO patients for covered services that are authorized by the HMO. The dispute arises, the state has an independent dispute resolutions process administered by a third party. So California has prohibits physicians from balance billing in emergency cases. The policy was established by a regulatory interpretation of the Knox-Keene Act by the Department of Managed Healthcare. And it treats all emergency department services as in-network and applies only to plans under the DMHC's jurisdiction, which is mostly HMOs and PPOs. In other words, it doesn't apply to plans under the Department of Insurance's jurisdiction. The policy was challenged in court by providers, but was affirmed unanimously by the California Supreme Court in the Prospect versus Northridge decision. That was in 2009. California requires that plans pay providers a reasonable and customary payment rate. Payment must be based upon statistically credible information that is updated at least annually and must take into account factors such as the provider's training and experience, the nature of the service provided, and the fees usually charged by a provider. Again, if the providers are unhappy with the plan's payment, they can use the state's voluntary, non-binding, independent dispute resolution process. And California has no disclosure requirements beyond the standard information required at the point of service regarding the use of out-of-network providers. It's interesting is DMHC also has the authority to enforce its regulations, which make it an unfair billing pattern for an emergency service provider to bill a health plan enrollee for amounts beyond in-network cost sharing. And it has reached, it's actually used its enforcement authority not only against providers, but also against insurers. California passed a new balance billing law, AB 72, signed into law September 13, 2016, but effective July 1st of this year. And it applies to health plans and health insurance policies issued, amended, or renewed on or after July 1st of 2017. It's under it, non-contracted providers are entitled to the greater of the average contracted rate or 125% of the Medicare fee-for-service rate for similar services in a similar geographic area. Doesn't apply to the Medi-Cal managed care plans whose beneficiaries already enjoy balance billing protections. State insurance and Medicaid managed care regulators must establish an independent process to facilitate resolution of payer-provider payment disputes. So here we are. We're going to end up here with talking for a bit about the Nevada Assembly Bill 382, which is currently pending in the Nevada legislature. So this bill only applies to emergency services, and in fact it specifically excludes other than service, does not include services to stabilize the patient. Only applies to patients who have insurance, and its goal is to get the patient out of the middle of the surprise billing dispute, put the dispute between sophisticated parties, the insurer and the provider. So it requires insurers to pay excluding any deductible copayment or co-insurance paid by the patient, the greater of, this sounds like California, the average amount negotiated by insurers with Nevada in-network hospitals, in-network physicians for the same or similar emergency services and care, and 125% of Medicare fee-for-service for the same or similar emergency services and care in the geographic region in which the emergency services and care are rendered. And it says that the commissioner of insurance is to adopt regulations that interpret the provisions of the subsection, including a system for verifying a negotiated contract price submitted to the commissioner of insurance by insurers described. So the commissioner has to come up with regulations to collect the information so that she can understand this first criteria here in the payment formula, the average amount negotiated by insurers with Nevada in-network hospital, in-network physicians for the same or similar emergency services. So who does this bill apply to? It applies to out-of-network hospitals with at least 100 beds, out-of-network independent centers for emergency medical care, which are essentially under Nevada law, freestanding emergency departments. And those are, if they're operated by the same person who operates such a hospital out of network. And then also to out-of-network physicians on the medical staff of an in-network hospital with at least 100 beds or in-network independent center for emergency medical care operated by the same person who operates such a hospital. So it requires out-of-network hospitals, and I'm calling the sort of the freestanding emergency departments IECs, requires out-of-network hospitals, IECs, and out-of-network providers to accept as payment in full the mandated rate, which we saw in the last slide, for ER services and care other than services care to stabilize the patient. And it requires that the patient was presented to an out-of-network hospital or IEC, out-of-network physician, for the provision of medically necessary emergency services, and has a policy of insurance or other contractual agreement that provides coverage to the patient for emergency services and care provided by more than one hospital and IEC in the state, other than the hospital or IEC to which the patient was presented. So an out-of-network hospital, an out-of-network IEC is not required to accept as payment in full that mandated rate greater of the average contracted rate and 125% of Medicare fee-for-service if the third party, that's what they're calling in the statute, it's really the insurer, that issued the policy of insurance or other contractual arrangement which provides coverage to the patient has not submitted the quarterly report required by Section 20. So the insurer has to provide the report, which we'll talk about in a few minutes, what that report has to contain. These are circumstances that if they exist, the out-of-network hospital or out-of-network IEC doesn't have to accept that mandated amount as payment in full. So if the insurer hasn't filed this report, the insurer has not in good faith participated in negotiation or mediation and has not documented the occurrence and outcomes of any negotiation or mediation. patient hasn't paid the deductible, co-payment, or co-insurance that the patient would have paid for the provision of emergency services and care at an in-network hospital, in-network IEC, or by an in-network physician, or the insurer has not paid the out-of-network hospital, out-of-network IEC, or out-of-network provider as applicable for the emergency services and care within 60 days after receipt of the bill, and all necessary medical records required to pay the claim, if applicable, within 60 days after the conclusion of any negotiation or mediation between the third party and the out-of-network hospital, out-of-network independent center for emergency medical care, out-of-network physician. So all of those, so any one of those instances, let's go back to the previous slide, any one of those is not satisfied, then the out-of-network hospital doesn't have to accept the mandated amount under the statute. So if the out-of-network hospital or out-of-network IEC or out-of-network physician for emergency medical care believes the amounts prescribed in the statute are insufficient to compensate it for emergency medical care for the emergency services and care provided, then they must, within 30 days of receiving the written notice of such amounts from the insurer, request in writing to enter into negotiations with the insurer to resolve the difference between the amount charged and the amount paid by the insurer. Such negotiations must begin within 2 weeks of the request for negotiations. If they don't result in agreement on the amount to be paid, the out-of-network hospital may file a complaint with the Governor's Health Advocate pursuant to NRS 222.560 and request the advocate mediate to determine the amount that must be paid for emergency services and care. And in no event shall the patient who received emergency care be responsible for payment of an amount greater than the deductible co-payment or co-insurance paid by the patient pursuant to his or her policy of insurance, or be required to participate in any negotiation entered into to this section or any mediation entered into. So this is all part of the patient would only have to pay what the patient would have to pay in network and doesn't have to participate in any negotiations or any dispute resolution process. So if an insurer who issues a health insurance contract in Nevada wishes out-of-network hospitals to accept this mandated rate, the insurer has to review its contracts with in-network hospitals, in-network IECs, and in-network physicians to determine whether a person who is covered by that policy of insurance or other contractual agreement that provides coverage for health care has adequate access to health care, including without limitation a review of the number and types of in-network hospitals, in-network independent IECs, and in-network physicians, including without limitation ER physicians, anesthesiologists, and specialty physicians, whether a person who is covered by the policy of insurance or other contractual agreement has access to in-network hospitals, in-network IECs, and in-network physicians without experiencing unreasonable delay in the provision of health care. And the in-network hospitals and in-network independent centers for emergency medical care, which provide emergency services and care, and the number and type of network physicians on the medical staff of those in-network hospitals, and in-network independent centers for emergency medical care to ensure that the insurer has contracted with a sufficient number and type of physicians who are on the medical staff of the in-network hospitals and in-network independent centers for emergency medical care. And they also have to review the frequency with which persons covered by the policy of insurance or other contractual agreement are treated for emergency services and the care by out-of-network physicians at in-network hospitals and in-network independent centers for medical emergency care, and the rate at which those services of care are reimbursed by the third party. And this is all in addition to having to comply with the commissioner's regulation, network adequacy regulation that was passed last year that requires insurers to submit on an annual basis the CMS form to determine whether or not they each have an adequate network. Part of the review also, in terms of the education part of it, ensure that persons covered by the policy of insurance receive adequate information regarding in-network hospitals, in-network IECs, in-network physicians, and the financial impact of receiving emergency services and care from an out-of-network hospitals, out-of-network IECs, and out-of-network physicians, including without limitation the financial impact of receiving ER services and care from an out-of-network physician on the medical staff of an in-network hospital or in-network IEC. The information must be provided in a format that's meaningful for persons making an informed decision concerning emergency services and care, and must be accessible to persons covered by the policy of insurance or other contractual agreement. Then they must submit once each calendar quarter, this is the report, to the Commissioner, the Legislative Committee on Healthcare, a report containing a summary of the reviews conducted pursuant to the sections I've just gone over and the educational efforts taken pursuant to subsection 3. Also, the hospital has, with 100 or more beds, is not operated by a federal, state, or local governmental agency. It has to submit to the department an annual report which includes the number of patients from whom the hospital or independent IEC has attempted to collect a debt for any amount owed to the hospital or independent IEC for emergency services, the number of patients for whom the physician on the medical staff at the hospital or person acting on behalf of such physician has attempted to collect a debt for any amount owed to the physician for emergency services and care, the amount of any increase in the rate negotiated with third parties for emergency services and care that exceeds the percentage of increase in the consumer price index, the medical care component for the year in which the rate is increased, and any justification for the increase, and the amount of any payment negotiated by the hospital or independent center for emergency medical care pursuant to or by the out-of-network negotiation options of the Act. Finally, there's I'm going to kind of skip over this because we're running out of time, but there's a procedure for filing and processing of complaints by the Advocate's Office. And more of that. So there's also an amendment to the network adequacy statute to make it dovetail with these provisions. So here's the final slide. And what happened on Saturday at a hearing before the Assembly Ways and Means Committee, Assemblywoman Maggie Carlton, who's chair of the Ways and Means, reported that the various parties failed to agree on the rate. That's the, the greater of average contracted rate and 125% of Medicare. So those provisions would be removed. They had an amendment in their hand. The other change, the insurer would make an initial offer to the facility or the provider to settle the balance bill, settle the outstanding bill, If the offer is unacceptable, the two sophisticated parties, the insurer and the hospital provider, could settle the matter with binding arbitration to the Governor's Health Advocate's Office. The patient's responsibility would still be limited to deductibles, copayments, or coinsurance under his or her insurance policy. The hospital argued that there needs to be reasonableness, good faith standard for the initial offer to settle by the insurer. So that's the current status of where this bill stands. No formal amendment making these changes yet. And of course, the bill hasn't even hit the Senate yet. So stay tuned. It'll be interesting to see how this one turns out. Thanks for joining me today. Appreciate it. Hope the information that was provided in this presentation was valuable. Thanks so much. Bye.